Welcome to the Peds NP, Pearls of Pediatric Evidence-Based Practice. As always, I'm your host, Dr. Becky Carson, pediatric nurse practitioner and associate professor at the Duke University School of Nursing. And I'm so happy to welcome you back to our Immunizations Update mini-series with an episode that tackles the new, contested, and frankly confusing vaccine schedules and how we can navigate them in practice. First, my disclosures. I do not receive any financial incentive to produce or distribute this podcast. This podcast is my scholarship and my personal approach to advocacy. So I want you to know that this podcast series is free from conflicts of interest and any secondary gain that could limit the credibility of my work. I'm so invested in credibility that I have 2 independent peer reviewers evaluate each episode before publication to watch for potential bias, conflicts of interest, and ensure accuracy. That kind of quality assurance doesn't happen in all podcasts, but it means that the Peds NP is one you can trust. To read more about the peer review process, visit thepedsnp.com and click Peer Review. All right, let's jump right into the vaccine schedules, what's changed, and why it's confusing to providers and families. We'll start with a little bit of history. The Advisory Committee on Immunization Practices, or ACIP, traditionally provides the Centers for Disease Control and Prevention, the CDC, and Department of Health and Human Services, DHHS, with recommendations that underpin the immunization schedule. But in 2025, all 17 members of ACIP were replaced by the newly appointed Secretary of DHHS, Robert F. Kennedy Jr. There were subsequent federal changes to the CDC ACIP processes and recommendations that led to substantial departures from prior consensus guidance, which was the source of litigation that we heard about in March of 2026 when a federal judge in Boston temporarily blocked a Trump administration effort to reduce the number of recommended childhood vaccinations from 17 to 11. Let's dig into those departures for a moment. So, starting in 2025, we saw changes to routine recommendations that directly conflict with existing expert guidance. These shifts culminated in early 2026 with major changes to the CDC child and adolescent schedule that removed several vaccines from universal recommendations without any meeting of ACIP, public comment period, or consultation with career vaccine experts. Instead, vaccines were placed into one of 3 categories. 1, recommended for all. 2, recommended for those considered quote-unquote high risk. And 3, used through quote-unquote shared clinical decision-making between families and providers when it is not possible for public health authorities to clearly define who will benefit from an immunization. The immunizations that shifted from the universal recommendation to either only for high risk or through shared decision-making include RSV, hepatitis A, hepatitis B, dengue, meningococcal ACWY, meningococcal B, rotavirus, COVID-19, and influenza. Before we go on, I want to pause real quick and define a term: shared decision-making. What is it? Montori et al. In 2022 tells us that anytime a patient or family and clinician figure out what to do together, that's shared decision-making. It's collaborative, considers the benefits and harms of each choice, and factors in things like preferences or other scientific knowledge necessary to support autonomy, beneficence, and non-maleficence. I must point out that this is our regular existing practice, not a novel approach to patient care that was absent in previous vaccine conversations. Just wanted to clarify that point. All right, back to our prior conversation. So, the new administration explained that their reason for these changes was the high number of mandated vaccines in the United States compared to other peer nations, and a waning confidence in public health endeavors at preventing disease that coincided closely with the COVID-19 pandemic. There are a number of problems with this, according to Dr. Sean O'Leary and a panel of vaccine experts at NAPNAP's 2026 National Conference in Pittsburgh. First was the process. There was no disease burden modeling to predict the impact of such changes. There was no public comment period, as is typical in major changes such as these. And there was no independent expert input. The opaque process was worrisome and seemed to prioritize the rumor mill over what was truly data-driven. The changes were focused almost solely on the number of vaccines delivered, rather than how many illnesses, hospitalizations, and deaths were prevented. They totally forgot to factor in economic interests that impact families, like missed revenue from having to stay home with your kids, much less incurring health-related costs. The most detrimental part was trying to make these changes based on, quote, peer nations, most notably Denmark. Denmark, for those of you who need a refresher, is about the size of Minnesota and has universal, tax-funded healthcare. You cannot simply copy-paste their public health efforts to the United States. Okay, so meanwhile, the American Academy of Pediatrics, the AAP, published and then reaffirmed its own schedule for 2025-2026, maintaining routine protection against 18 diseases and preserving long-standing universal recommendations. The AAP has been making its own recommendations for 90 years, far longer than ACIP, which was created in 1964. And the AAP has often engaged with interested institutions to collaborate on their vaccine recommendations. In years past, the AAP schedules tended to be similar to ACIP's, but there has been a stark divergence in the last year. AAP leaders cited a lack of supporting data for downgrading universal vaccines on the federal schedule and a process that did not follow traditional ACIP public meeting review and a history of misinformation spread, prompting the AAP to then publish their independent, evidence-based schedule endorsed by multiple health organizations. As we continue in this episode, I want to share that I follow the AAP schedule, and that's what I want to help you translate into your practice and pediatric workflow. Even though a judge blocked the immunization schedule change, I think we're going to continue to see changes in this arena, and it's important for you to understand what's happening so that you can follow the progress. Okay, so what's the difference between the AAP and CDC schedule? The most notable difference you'll see is the AAP's continued universal recommendations, meaning that they recommend infants, children, and adolescents receive immunization against all 18 previously recommended diseases, while the federal CDC schedule recategorized multiple vaccines to downgrade recommended protection and instead used this shared decision-making approach or a focus on high-risk patients. What adds to the waning confidence and confusion is the CDC's use of 3 different tables, which could be easily overlooked. The AAP table distinguishes vaccines that are only necessary in high-risk situations with a yellow-colored box, but keeps it on the same schedule. So, for example, dengue vaccination is only necessary for children in the recommended age who are both in an endemic region and have previously had dengue fever. Similarly, the RSV vaccine Abrysvo is only necessary in adolescent females who are pregnant and have not previously been vaccinated. Having different charts may mean that entire groups get missed, even though the fine print recommendations stay the same. Let's talk about a couple of notable examples and see how they practically play out. For HPV, the CDC followed evidence and peer nations that advise that the vaccine is equally efficacious at 1 dose, but also delayed the recommendation of administration to 11 to 12 years. The Association of Immunization Managers noted that, quote, while there is evidence that 1 dose of HPV vaccine may be as effective at preventing cervical cancers as a 2 or 3 dose regimen, the evidence does not include outcomes past 12 months, end quote. So, how can we be sure that protection is sustained from adolescence through young adulthood when it's mostly needed? What's also missing is FDA approval for a 1-dose regimen. The FDA-approved regimen is 2 doses. So what is the push for 1 dose? This is Becky talking here. I personally think it's an effort to give fewer vaccines, which is what we see in other countries who use the 1-dose regimens, mostly because of access and financial considerations. And if we're trying to copy peer nations, well, the CDC missed the mark because Denmark recommends a 2-dose series. There's a good chance that a 1-dose HPV regimen is in our future because there are numerous high-quality studies that support it. I'm just in favor of having the discussion and making the decision in a rigorous and informed way. All right, next up, RSV prevention for infants. The AAP retains routine protection pathways through maternal vaccine or infant immunoprophylaxis and flags that most infants whose mothers weren't vaccinated need protection. And here's where flippant word choice by the CDC and changing the schedule can be really fusing for providers, and it alters public confidence. The CDC moved nirsevimab to a schedule titled Immunizations Recommended for Certain High-Risk Groups or Populations. Then it lists the RSV monoclonal antibody with a footnote stating that all children whose mother did not receive the vaccine should get the dose. Let's read and shout the fine print. All children not previously protected need nirsevimab. They even go on to offer another footnote stating high-risk children, such as those with chronic lung disease, should receive a second dose at 8 to 19 months. This is consistent with the historic and AAP recommendation. But when the CDC moved it to a different schedule intended for, quote, high-risk children, families are going to miss that all children are part of this recommendation. So how do you navigate this with families? I think the data speaks for itself, and so do the footnotes. RSV is the leading cause of illness in infants, with over half being infected during their first year of life. Of those, around 3% require hospitalization, namely for a lower respiratory tract infection. Those numbers don't sound so compelling, do they? Well, we need to get more granular. In the CDC's Morbidity and Mortality Weekly Report from February 19, 2026, Silk et al. Reported that RSV was associated with 190,000 to 350,000 hospitalizations and 10 to 23,000 deaths. Most of these deaths were actually in elderly people, but here's the kicker. The highest hospitalization rates occurred in infants less than 12 months of age, despite the fact that RSV-associated hospitalization rates in infants 0 to 7 months were reduced by 28 to 43% compared with seasons preceding RSV vaccines and monoclonal antibody. Okay, if you need a translation, here it is. RSV is bad news for babies, and nirsevimab and Abrysvo help tremendously. In a retrospective chart analysis of children with RSV, Payne et al. Found that nirsevimab was 77% effective against ED encounters and 98% effective against hospitalization. If you need more information about nirsevimab, check out the PedsNP episode 65 or the article Practical Application of Nirsevimab Recommendations for Infants and Toddlers in the Journal of Pediatric Healthcare. So, how should we be approaching these issues with families? That's a great question. Words matter, and conflicting messages erode confidence. Let's be clear, vaccines have always required informed consent. So, the inclusion of a category of vaccines that are part of shared decision-making is redundant and creates an image that is in opposition to the practices already in place for all vaccines under federal law. I'd recommend getting to know the CDC schedule so that you can know where the discrepancies are and then explain the clinical rationale for the AAP pathway or better explain how they are exactly the same despite conflicting messaging. All right, well, what about the presumptive approach? That is a great question. The presumptive approach recommended by the AAP instructs clinicians to frame conversations around vaccines with the assumption that they will accept them. It's not, would you like this vaccine or would you like that vaccine? It's, your child is due for this and that vaccine today. You'll hear my thoughts on this later in this series, but for now, I want you to be prepared for hesitant conversations by knowing the similarities and differences between the two schedules and engaging in meaningful discussions about vaccines. After all, a conversation with a trusted healthcare provider is the most meaningful indicator of vaccine acceptance, so it's essential that you know the science. All right, well, what are the implications for insurance? Well, the federal government policies for coverage of vaccines are enmeshed in the CDC schedule, leading to big questions about coverage for the Vaccines for Children program and Medicaid. Because the change in the CDC schedule was not based on an ACIP vote, and the VCP coverage of vaccines is based on ACIP recommendations, the administration has stated that VFC and Medicaid coverage will not change. DHHS told us in a fact sheet on their website that all immunizations recommended by the CDC as of December 31st, 2025, will continue to be fully covered by the Affordable Care Act insurance plans and federal insurance programs, including Medicaid, the Children's Health Insurance Program, and the Vaccines for Children program. Families will not have to purchase them out of pocket. The truth is, this could change at any time. And if coverage were removed, state Medicaid programs could cover them, but each state would have to foot the bill and would be subject to federal oversight by the Centers for Medicare and Medicaid Services. On a happier note, the outlook is good on the horizon for all AAP-recommended vaccines being covered by commercial insurers because vaccines are fiscally advantageous to insurers. They're generally inexpensive compared to health-related expenditures from disease burden. Individual states can also help out by requiring insurance companies to cover certain vaccines, which is what occurred with the COVID-19 vaccine. None of this coverage is guaranteed, so it's yet another reason to reach out to your local elected officials as an advocate for children. All right, here's a tough one. What about the medical liability for giving vaccines not recommended by the CDC? All right, that is a fair worry because the National Vaccine Injury Compensation Program, which is a federal no-fault system that limits civil liability for vaccine injuries, only covers vaccines recommended by the CDC. The discrepancies in the CDC and AAP schedules potentially expose clinicians to liability for injuries or the claim that it was malpractice to have recommended a vaccine. Mello et al. In 2026 walks us through the issues of medical malpractice by sharing that the burden in such cases is actually on the plaintiff to demonstrate negligence by the provider. And that would be difficult in this case because our national authorities on vaccines, the AAP and the CDC, have differing guidelines on how to manage care. So adherence to any guideline can be considered reasonable rather than negligence. There are 12 medical societies, including our very own National Association of Pediatric Nurse Practitioners, that endorse the AAP vaccine schedule. So the number of voices in support of their practices just got louder. It's always good practice to counsel on the risks and benefits of any intervention and document accordingly. Do you think accessibility could be impacted by this change? Yeah, sure, I do. Especially when you think about states where pharmacists administer vaccines. State law determines which vaccines pharmacists may administer and under what conditions. So changes to the recommended schedule can impact states whose statutes support the CDC, leaving some pharmacists unable to administer a vaccine that's not on the CDC schedule. It's also confusing to consider what shared decision-making looks like in a pharmacy, where there isn't exactly an intentional health promotion visit. Instead, patients usually just ask for it, and the pharmacist is there to provide access. But I'd recommend that our retail pharmacy colleagues remain informed on common questions that may surface, especially surrounding safety. Okay, what should I do when a family wants to follow the CDC schedule? When families opt out after counseling, document the divergence with inclusive phrasing that leaves the door open for opportunities to have continued discussions at the next visit. Something like, family elected to follow federal shared decision-making model for influenza and COVID vaccines. Recommend transition to AAP schedule at future visits. Let's finish up with some practical tips that you can use in conversation with families when questions undoubtedly arise. First, you'll want to make sure that you standardize your AAP first clinic stance. Don't forget to review and update standing orders, EMR health maintenance logic, discharge summaries, and vaccine alerts to mirror AAP 2026 guidelines. Next, build a parent script on how to explain the schedules and your rationale. Something like, our clinic follows the AAP guidelines. You may see another schedule online that pairs back routine vaccinations. In pediatrics, we're following the AAP schedule because it's grounded in U.S. data and has the strongest safety oversight. It keeps your child protected against 18 diseases that still cause hospitalization and outbreaks when we let coverage slip. You should share trusted information with families that align with the science. Post QR codes to your portal where families can get information like the AAP schedule PDFs and the specifics of what they can expect at each visit. Make sure that the ancillary staff, like nurses and medical assistants, are also updated on messaging with pearls that they can use to educate families consistently across the practice. I'm so grateful that you took the time to listen and learn today, because I know that it can be difficult to keep up with regular life, much less drastic changes to the ways we prevent disease in children. Your advocacy is not lost on me. You're a rock star, and I know you keep good company. So share this episode with other pediatric providers who also need to hear it. Full transparency here, you can check my references in the show notes and even reach out to me by email at thepedznp@gmail.com or DM me on Instagram at thepedznppodcast. Make sure to follow and like this podcast because it will help this grassroots, evidence-based, peer-reviewed content reach other listeners. And remember, this is more than just a podcast. It's keeping kids healthy through trusted conversations. I'm Becky Carson. Take care.